Thank you all for joining us for this webinar, which is part of our series of presentations focused on applying evidence into practice, which is part of the comorbidity project funded by the Australian Government Department of Health and Aged Care. My name is Christina Morell. I'm an Associate Professor and Program Lead of Treatment and Translation in Complex Populations at the Matilda Centre for Research in Mental Health and Substance Use at the University of Sydney. Along with Alexandra Azzi, who is a project officer on this project, I have the pleasure of facilitating today's webinar, which is being presented by Associate Professor Louise Mewton. Before we start, I would like to acknowledge and pay my respects to the traditional owners of the lands on which we are meeting and recognise, of course, that we are across Australia today. The traditional owners of the lands that I'm currently on are the Gadigal peoples of the Eora Nation, but I would like to also pay my respects to other traditional owners of the lands across Australia for everyone else who is here. And I would also like to take a moment to recognise and acknowledge the many people with lived and living experience of mental illness and substance use, as well as their families and carers, many of whom have generously contributed to the development of the guidelines and of co-occurring conditions, as well as our other resources. If you've been to one of our webinars before, you would have heard me give this little spiel about Zoom before, in which case, please feel free to let your attention wander freely while I just go over a couple of things before we get started. First of all, to let you know whether you're joining us live or watching this recording later, you are all in listen-only mode, which means we cannot see or hear you. So just to draw your attention to the Q&A and chat buttons on your screen, feel free to click on the Q&A button and type in any questions that you have at any time during the presentation today. We should have some time for discussion at the end of Louise's presentation, and we will try to go through as many of those as we can. If you have any comments or anything that is not for Louise, please use the chat. This recording and slides will both be available to download from the website on your screen there in the next few days. If you find Zoom distracting, Zoom's chat distracting, I should say, you can have a play around with the settings on your end to disable what messages you see. And to do this, you just need to go to the Zoom desktop app if you have it installed, click on the settings wheel in the top right-hand corner, and select Change Chat on the navigation menu, and you can have a little play around with what messages you see by turning off your notifications. And the link to do that is on screen, and Alex can post that in the chat. So to get started, today's webinar is on alcohol use and older adulthood, the physiological impacts and effective treatment options. And I will hand over to Louise in a moment to get us started. But just before I do, I want to mention that we have some more webinars coming up over the next few months. You can find out more and also register for those at our website, and the link to do that is on screen. If you've been to one of our webinars before, you might remember that we ask for suggestions at the end of every webinar. So please take a minute if you have it at the end of our session today to let us know if you have any burning topics you'd like to see as part of this series, and we'll see what we can do. So now it is my very great pleasure to introduce or hand over to Louise to get started and introduce her as well. Just one second while I get myself organized here. Okay, so Louise is an Associate Professor and Public Health Researcher with a focus on the epidemiology, assessment, prevention and treatment of alcohol use and related disorders across the lifespan. She's Program Lead in Lifespan and Brain Health Research at the Matilda Centre at the University of Sydney. So very glad that she could be here today to talk about, to talk with us today. And I'm going to hand over to her to get us started. Thank you so much, Lou.
So thank you so much for the introduction and welcome everyone, and thank you for coming along today. So I am going to be talking about alcohol use in older adulthood. I'm going to be talking about the physiological impacts, particularly the cognitive impacts, as well as effective alcohol treatment options for older adults. So I would like to begin today by acknowledging the Gadigal people, the traditional custodians of the land on which I am presenting from today. I extend that respect to Aboriginal and Torres Strait Islander people here today. And I also acknowledge the traditional custodians of the lands from which you are all joining me from. Okay, so in terms of key learning outcomes from this webinar, first, I'm going to be talking about the physiological impacts of alcohol use on older adults. Then I'm going to be talking about the impact of alcohol use on the brain of older adults, including the relationship between alcohol use, cognitive impairment, and dementia. And then finally, I am going to be talking about effective approaches for treating harmful alcohol use in older adults. Okay, so first, how do we define older adults? So in the general population, older adults are defined as those aged over 65 years. But for Aboriginal and Torres Strait Islander people and people attending substance use disorder services, older adults are actually defined as those aged over 50 years. So we're seeing a change in the demography in Australia as well. What we're seeing is a greater proportion of older adults in the population. So in 2017, nearly 4 million Australians were aged over 65. So that was about 15% of the Australian population. In the next 50 years, this is expected to increase to 9 to 10 million people, or 21 to 23% of the total population. So Australia's population is aging. And at the same time, we're also seeing changes in patterns of alcohol use over time, particularly by different age groups. So we can see here from the most recent data from the National Drug Strategy Household Survey, that while we're seeing some really sharp declines amongst younger age groups, we're not seeing equivalent reductions amongst our older age groups. We're seeing that over time, the rates of risky drinking amongst these older age groups are fairly stable. And this is over the past 15 years or so. And here we have data on treatment episodes, alcohol-related treatment episodes. So this includes data on things like assessment, counselling, support and case management, withdrawal management, rehabilitation, psychoeducation, and pharmacotherapy. So all those different treatment episodes captured here. So while treatment episodes are decreasing among younger age groups, we can see that treatment rates are increasing among older age groups. So we see here, for example, we've got 10 to 19-year-olds, and we're seeing decreases there in treatment episodes. We're also seeing decreases in this 20 to 29-year-old age group. We're seeing that in the 30 to 39-year-olds that rates are fairly stable. And then we're starting to see an increase here. So in the 40 to 49-year-old age group, we're seeing increases in treatment episodes, in the 60 to 69-year-old age group, and in those who are aged over 60. So this could reflect our aging population, or the fact that more recent generations of older adults, so the baby boomers, for example, have had more exposure to alcohol. So what we're seeing is a shift in the demography of alcohol-related treatment episodes. So clinicians are now more likely to be seeing older adults in their care. Okay, so here we have different types of older adult drinkers that may be coming into care of various services. So these have been taken from the most recent Australian alcohol treatment guidelines, and we've got a link to those there. So we've got three different types of older adult problem drinkers. So the first is a survivor group. So these are early onset users. These are people who have developed alcohol use disorder in their 20s, and they prematurely age as they don't use preventative services and may require aged care related services in their 50s. So it is this group, these survivors, that really contributes to the revision of the definition of older adulthood among those seeking alcohol services. Then we've got maintainers, and these are people whose long-term risky alcohol use only starts to manifest itself as an overt problem as age-related changes occur. And previously well-tolerated, although excessive, consumption of alcohol is no longer tolerated or results in harm. So these are people who have been drinking at excessive levels since they were young. As they're getting older, they're no longer able to tolerate that amount of alcohol, and we're seeing harm as a result, alcohol-related harm as a result. And then finally, we've got our reactors, or our late onset users. These are people who develop alcohol use disorders after the age of 50. And this may occur in association with issues that are also more prevalent in older adulthood. So things like declining health, chronic pain, stress, insomnia, bereavement, unemployment or retirement, depression, social isolation, and boredom. So what we do know is that 1 in 3 older adult problem drinkers will develop their problem drinking in later life. So about a third are in this reactor group. What we have next are a few vignettes focusing on this reactor or this late onset group. So these videos have been produced as part of the Drink Well, Age Well program in the UK, which I will talk a little more about later.
Welcome to another episode of Vintage Street, where we take a closer look at more mature humans in their natural habitat. We will explore the survival techniques they adopt and how they adapt to their surroundings as they get older. Firstly, let us peek into the nest of lovebirds, Jackie and Derek, returning home after gathering their weekly big shop. Ah, we're seeing this live now. The female produces their weekly supply of booze, 6 bottles. Booze is a favored human ritual for relaxation, despite its link with over 60 health conditions. With their offspring all grown up and having flown the nest, Jackie and Derek are increasingly enjoying their evening tipple as the long evenings stretch out without the busy chirping of family life. Now, viewers, we are lucky to observe the behavior in this lion's lair. Having been the pride of the pack for many years with many responsibilities, this particular species, Kevin, has now retired to live out his life in quiet solitude. Kevin puts his new fondness for daytime drinking down to having more hours to fill. He didn't think his long-anticipated retirement would leave him feeling quite so bored. Our final human species of this episode is Liz. She has become increasingly isolated from her pack since losing her life partner Frank. Liz and Frank were the life and soul of every party, and always the last pair standing. But sadly, Frank died from bowel cancer last year. Liz is using booze for more than relaxation. She is using it to numb her grief and pain. Most painful for Liz is that she can't have her granddaughter, Ada, for overnights anymore. Do you recognize any of the humans on Vintage Street? Harmful drinking is increasing more in the over 50s than any other age group. Life changes we will all go through, retirement, empty nest, bereavement, may trigger us to drink a little more often and a little more than we should. To find out more about making healthier choices about alcohol as we age, go to drinkwiseagewell.org.uk.
So that video really demonstrating some of the triggers for late onset drinking and how life events may lead some older adults to start drinking in a problematic way. And why should we be concerned about risky drinking in older populations? There are physiological changes associated with aging that may place older adults at greater risk for alcohol-related harms. So these include things like decreases in lean body mass and total body water. And what this means is that it leads to a higher blood alcohol concentration for a given dose. In older adults, we also see less efficiency in the liver enzymes that metabolize alcohol. Older adults are also more likely to experience multi-morbidity and related medication use or polypharmacy. And this puts them at higher risk for the negative consequences of alcohol. In older adults, we also see greater susceptibility to the acute cognitive effects of alcohol. And this can result in things like an increased risk for injuries and falls. But what I'm particularly interested in are the chronic cognitive effects of alcohol and the impact of alcohol use on cognitive impairment and dementia. Okay, so first to focus on alcohol-related brain damage. So the first thing I'm going to focus on is Wernicke-Korsakoff syndrome. Now, this is caused by severe thiamine or vitamin B1 deficiency, and this can be due to poor nutrition and inflammation of the stomach lining. So Wernicke-Korsakoff syndrome is a serious brain condition that is usually, but not exclusively, associated with chronic heavy alcohol use and severe alcohol use disorder. The prevalence of Wernicke-Korsakoff syndrome across populations is not well established, and researchers estimate that it may actually be undiagnosed in approximately 80% of patients. Without treatment, Wernicke-Korsakoff syndrome can be disabling. It can produce permanent memory loss, and it can be life-threatening. So what we have here are MRI scans of a healthy male at the top here, and then at the bottom here, another male at the same age with Wernicke-Korsakoff syndrome. So what we can see is that the Wernicke-Korsakoff brain has less brain volume altogether and larger cavities within the brain. So these are called ventricles. So Wernicke-Korsakoff syndrome may result from other conditions that involve malnutrition and thiamine deficiency. So these are things like cancer, AIDS, excessive vomiting, perhaps due to pregnancy, and gastrointestinal or bariatric surgery. But these cases are far less prevalent than cases associated with severe alcohol use disorder. So in terms of the symptoms of Wernicke's disease, so Wernicke's is the acute phase of the disease, and symptoms include things like confusion, a lack of energy, hypothermia, low blood pressure, and sometimes coma. We also see a lack of muscle coordination that can affect things like posture and balance and can lead to tremors. There are also vision problems, such as abnormal eye movements, double vision, misaligned or cross-eyed, and eyelid drooping. So the early symptoms of Wernicke's can be reversed if detected and treated promptly and completely. So Wernicke's disease should be considered a medical emergency. Wernicke's disease is treated with intravenous administration of thiamine and glucose. So although some symptoms of Wernicke's, such as the muscle and vision problems, are reversible with prompt thiamine treatment, other symptoms may respond more slowly or may not be completely reversible. And without prompt treatment, Wernicke's disease can progress to the chronic Korsakoff syndrome, which is not reversible. So symptoms of Korsakoff syndrome include potentially severe and irreversible memory impairments, including problems forming new memories and recalling memories as well. There's also this confabulation, this making up of inaccurate stories about events or remembering events incorrectly. There can also be an experience of hallucinations, so it's sometimes called Korsakoff psychosis because of this. We see repetitious speech and actions, problems with executive functioning, so that's things like decision making, as well as planning, organising and completing tasks, as well as a lack of motivation and emotional apathy. So in Korsakoff, severe memory loss and other damage can become permanent. Treatment for Korsakoffs include, again, intravenous thiamine replacement therapy, as well as oral supplements of thiamine for several weeks. There's also a need for proper nutrition, hydration, and other medications to manage specific symptoms. So aside from the thiamine therapy in the short term, there is no one optimal treatment for Korsakoffs. The treatment will often vary depending on symptoms, severity, and other co-occurring problems, so psychosis perhaps, or other major psychiatric disorders. Memory rehabilitation therapies, similar to those provided for various forms of dementia, can be effective in lessening the symptoms of Korsakoffs, but severe cases often require residential care. So in addition to Wernicke-Korsakoffs, we also have criteria for an alcohol-related dementia. Now, these have been proposed. They've been proposed quite some time ago, more than 20 years ago, but they still do require more validation. There's some controversy over whether this primary alcohol-related dementia exists. So while the impact of alcohol on the brain in Wernicke-Korsakoffs is indirect, it's through its impact on thiamine, or through a thiamine depletion that we see the impact on the brain. Alcohol-related dementia is thought to arise from the direct neurotoxicity of alcohol in the brain. So in terms of the criteria, what we have here is cognitive impairment that alters independence in activities of daily living. There needs to be evidence of quite heavy drinking over quite a sustained period of time. It's supported by the presence of other alcohol-related organ damage, so liver damage, for example, as well as ataxia attributable to brain atrophy, so some evidence from neuroimaging. It differs from other dementias in that cognitive impairment and brain atrophy may improve with extended abstinence. So unlike the other dementias, it's not necessarily degenerative. And it's discriminated from things like Alzheimer's disease through better performance on semantic and verbal memory, but then poorer performance on visuospatial tasks. So that poor performance on visuospatial tasks really a core feature of this alcohol-related dementia. So there's evidence for alcohol-related brain disorders, whether that's through the direct neurotoxicity of alcohol, like in alcohol-related dementia, or through indirect pathways, such as through thiamine depletion, which is what we see with Wernicke-Korsakoffs. There's also evidence suggesting that chronic heavy alcohol use, specifically alcohol use disorders here, are quite strongly related to all-cause dementia, including things like Alzheimer's dementia. So this was a French study conducted a little while ago. It included 31 million adults discharged from hospital. So this is a hospital record study. Over 1 million were diagnosed with dementia, and 60% of early onset dementia cases were directly alcohol related. So a really strong relationship there between alcohol use disorders and early onset dementia. Alcohol use disorders were also the strongest modifiable risk factor for all-cause dementia. And that's when compared with other more established risk factors for dementia, so things like high blood pressure, less education, and obesity, for example. So we can see that chronic heavy alcohol use and alcohol use disorders are associated with really quite serious brain disorders. Alcohol use is also related to cognitive impairments more broadly, including impairments that may not be at the level of those disorders that we've discussed so far. So it's estimated that 50 to 80% of those with alcohol use disorder demonstrate significant cognitive and behavioural compromise, and that about 30 to 40% demonstrate compromises at the level of clinical impairment. So alcohol impacts cognitive functioning in multiple different domains. So first there's executive functioning, which is things like attention, working memory, problem solving, inhibition, and flexibility. It also impacts visuospatial functioning. It impacts gait and balance, new learning and memory, and emotion processing and social cognition. So you can see how these impairments in cognitive functioning may impact treatment for older adults, which is something that we will go into a little bit later. So we saw earlier some of the brain correlates of Korsakoffs, but even cognitive impairment that doesn't reach the level of disorder is associated with impacts on the brain, as indicated in neuroimaging studies. So neuroimaging studies show that alcohol-related cognitive impairment is underpinned by things like a loss of brain volume in grey and white matter, particularly in the frontal areas. We also see compromised white matter integrity, larger ventricles in the brain, and compromised brain activity and connectivity as well. But on a positive note, we also know that recovery from alcohol-related cognitive impairment is possible. So these are results from a meta-analysis of 62 studies, which indicated that abstinence sustained for 12 months results in cognitive improvements across 11 different domains. And these improvements were in a small to moderate effect size range. So what they saw in this study was substantial improvements occur within the first 4 to 6 weeks of abstinence. And then these are followed by modest gains for up to 12 months. Verbal skills tend to improve most quickly, while other domains may remain compromised for longer. So things like inhibitory control, for example, may take longer to recover. These improvements in functioning are underpinned by improvements in brain structure and function. And while the bulk of research really focuses on cognitive recovery following abstinence, there is also some evidence that improvements can be achieved in the context of reductions to less harmful drinking. So from chronic heavy alcohol use or alcohol use disorder, for example, reducing to low to moderate drinking, but we do need more evidence looking at those sorts of outcomes. So this evidence around recovery really highlights how important it is to effectively treat problematic or harmful alcohol use, because we're seeing these improvements in cognitive functioning and brain health following effective treatment. Okay, so now we are going to focus on the treatment side of things. And we're going to go into some of the effective treatments for older adults. So first, I'm going to focus on some of the recommendations from the Australian Alcohol Treatment Guidelines. So the 4th edition of these guidelines was published in 2021. And these guidelines provide information that's specific to older adults as a priority population. So first, to focus on screening in alcohol, screening for alcohol, problematic alcohol use amongst older adults. The first recommendation is that regardless of the healthcare setting, screening for harmful alcohol use should be undertaken for all new patients over 50 years old, and that this should be reviewed at regular intervals, at least once a year. Now, the CAGE and the Alcohol Use Disorder Identification Test, the audit, so the CAGE and the audit are the most frequently used tools for screening alcohol dependence and hazardous use in the general population. And these have been validated for older populations as well. So the next recommendation is that for older adults who present with unexplained symptoms, both physical and psychological, as well as inconsistencies or contradictions in their presentation, as well as those who are experiencing major life events, should prompt re-screening for an assessment of alcohol use and other substance use. Concurrent physical or mental illness, medications, social conditions, and functional limitations need to be considered when assessing people who are older. So really thinking about, with those functional limitations, about things like cognitive screening, which I will go into next. There's also this need to reassess any comorbid physical and mental conditions several weeks to months after the cessation of drinking. So as we've seen, abstinence can be associated with marked improvements. So we might see marked improvements in these conditions, but on the other hand, alcohol use may also be masking underlying illness. So these may come out, so new physical and mental conditions may become apparent after long-term abstinence in older adulthood. Okay, so in terms of cognitive screening, the most widely used cognitive screening tool is the Mini Mental State Examination, or the MMSE. And this is well validated for use in the screening of early dementia, but it does have limited sensitivity in the detection of alcohol-related cognitive impairment. The MMSE is also copyright protected. So what we have here is the Montreal Cognitive Assessment, or the MOCA, and it's currently the most well-validated tool for use with individuals with alcohol use disorder. Now, in terms of advantages, it has good sensitivity and specificity for cognitive impairment in populations with alcohol use disorder. It assesses those cognitive domains that are most likely to be impaired in people with alcohol use disorder. So that visual, spatial, executive functioning, naming, attention, memory, language, abstraction, and orientation. There are also multiple formats, and it's available in multiple languages, and it's freely available for non-commercial use. And these are again taken from the Australian Treatment Guidelines. So another screening tool also recommended by the Australian Treatment Guidelines is the Addenbrooke's Cognitive Examination 3, or the ACE-3. So it assesses, again, those cognitive domains that are more likely to be impaired in alcohol use disorder. So things like attention, memory, fluency, language, and visuospatial function. Again, multiple formats, multiple languages, and it is freely available for clinical practice and research. And the last cognitive screening tool recommended as part of the Australian Treatment Guidelines is the repeatable battery for the assessment of neuropsychological status, or the RBANS. So again, able to detect cognitive impairment in individuals with alcohol use disorder. It assesses those domains which are likely to be impaired. So delayed memory, visuospatial and constructional ability, language and attention, and multiple formats available. In terms of disadvantages, this one does take longer to administer, and it does have a cost associated with it as well. Okay, so a more comprehensive assessment of cognitive functioning, so a full neuropsychological assessment, is recommended where cognitive impairment persists following extended abstinence, and particularly when there are concerns about the impact of cognitive impairment on functioning, so the ability to return to work, for example. So cognitive impairment can affect things like motivation, it can affect attention span, it can affect the ability to acquire new skills. All of these things affect treatment, but they can also and often do improve after a period of abstinence from alcohol. So clinicians should take into account the possibility of improvement in cognitive functioning by allowing a sufficient time, so there's 1 to 2 months of abstinence, to elapse before finalising any treatment planning. So the results of the neuropsychological assessment can inform appropriate alcohol use disorder treatment. It can also let us know whether other interventions are required. So the need for guardianship, for example, or the need for involvement of aged care or disability services. So following this full neuropsychological assessment, the clinician should discuss the results with their patient and their supporting networks. And they should also provide written material for patients in an easily understood format. So it is important to include treating clinicians and support networks in this discussion because the patient themselves may lack the ability to retain knowledge of and also to enact the recommendations that come out of the neuropsychological assessment. Okay, so now to focus on treatment. Here we have recommendations from the Australian Alcohol Treatment Guidelines for the treatment for older adults. So brief interventions should be employed for older people drinking at risky levels or experiencing alcohol-related harms. So here we're talking about people in the harmful to hazardous range of drinking. So you've done your screening and people are in this harmful to hazardous range of drinking. Older adults benefit from treatment, certainly, and in some cases they actually tend to have better outcomes than younger people. In particular, they tend to have higher compliance and retention rates. So there is evidence to suggest that older adults respond well to brief interventions, so things like motivational interviewing and enhancement approaches, as well as things like personalised feedback from their treating doctors. Things like drinking diaries, psychoeducation, and active follow-up letters or phone calls, which specifically address alcohol use, are also effective tools in reducing the amount or the frequency of alcohol consumption in older adults. So in terms of the evidence for these interventions, it is somewhat sparse. Here we have a systematic review, which was conducted a few years ago now, but really focusing on interventions to prevent and reduce excessive alcohol consumption in older adults. So as part of this review, they identified 13 different interventions, 13 studies were included. Now they were interested in looking at both reductions in alcohol use as an outcome, as well as improvements in cognitive functioning. So whether any of these interventions resulted in improvements in cognitive functioning. But none of the studies that they identified as part of this review looked at cognition as an outcome. So 6 of the 13 studies did show reductions in alcohol use. There was limited evidence that suggested that these more intensive multi-component interventions with things like personalised feedback, physician advice, educational materials, and active follow-up could be most effective. But there was also evidence as part of this that simple interventions in things including simple leaflets, alcohol assessments with advice could also have a positive effect in terms of reducing alcohol use in older adults. So to address the lack of effective interventions specifically designed for older adults, we recently developed the online Rethink My Drink program. Now, this is a program specifically designed for older adults aged over 60 years. And the intervention includes information and facilities for providing feedback to patients on their alcohol use. It also includes tools to aid behaviour change and a whole lot of information that's really specific to those aged over 60 years. So the program is theoretically informed and based on behavioural treatment principles. So it offers 3 phases across these 4 modules. Each of these modules is divided into different levels. The levels have different tasks and exercises associated with them. So it provides this sort of natural progression through the different phases. So phase 1 is really focused, phase 1, module 1 is really focused on decision making. So should I cut down? And it's based on motivational enhancement therapy. Phase 2, which are these 2 modules here, modules 2 and 3, really focuses on implementing change. So reducing alcohol use, so planning to cut down and cutting down. And it uses cognitive behavioural therapy as well as behavioural self-control principles. And then module 4, which is phase 3, is based on best practice principles of relapse prevention for older adults. As part of this intervention, there are several interactive e-tools, including things like a thinking drinking diary, where users record their alcohol consumption along with emotional and behavioural triggers and responses. There's several other interactive tools included in there as well. And these are really to enhance engagement as well as to aid behaviour change. So over the past couple of years, we have been testing this intervention in the Rethink My Drink trial. So what we wanted to know as part of this trial was whether an online brief alcohol intervention could reduce alcohol consumption in older risky drinkers. And we also wanted to know whether our intervention could have an impact on cognitive outcomes in older risky drinking. So really addressing that gap in the literature that was identified as part of that previous systematic review. So we have conducted a 1-to-1 parallel group randomized controlled trial. To be eligible, people did need to be scoring over 5 on the alcohol use disorder identification test. They needed to be 60 to 75 years old as well. Now, we recruited nearly 900 older adults, and it was really easy to recruit our participants for this study, really showing that the sort of need that's out there for a program like this. So 75% of our sample completed the post-intervention assessments and 55% completed the 12-month follow-up assessments. And that's really excellent, considering that this was conducted completely online with no face-to-face components at all. So we have just completed our preliminary analyses, and we're very excited with some of the impacts that our intervention has had in terms of both reducing alcohol use and improving cognition as well. So we're very much hoping to have the findings from this study published soon, and then have the Rethink My Drink intervention available for the public. Okay, so we've covered guidelines for high-risk drinking in older adults, for screening for high-risk drinking in older adults, as well as brief interventions that may be effective in this population. But what about when we get to the pointier end of problematic drinking, including things like chronic heavy alcohol use and alcohol use disorder? So here we have the treatment guidelines again, this time for managing withdrawal in older adults. Now, due to the complexities and physiological changes associated with older adulthood, as we've covered previously, older people do have an increased risk of a complicated alcohol withdrawal experience. As a result, it's really important to carefully assess and closely monitor older patients who are at risk for developing alcohol withdrawal complications. Ideally, this should be done in those risky patients in an inpatient setting. So there should be some caution exercise when prescribing medications to older adults. Short-acting benzodiazepines, so oxazepam and lorazepam, are recommended for the management of alcohol withdrawal symptoms, but it is noted that older adults are likely to require lower doses of benzodiazepines for the management of their withdrawal symptoms. So we have discussed thiamine deficiency, and that it's common among people with severe alcohol use disorders and can be related to severe consequences, so things like Wernicke-Korsakoff, for example. So there is good empirical evidence to support the use of thiamine injected intravenously during the admission for alcohol withdrawal management in older adults. And finally, we come to the guideline for relapse prevention. So in terms of relapse prevention, psychological and pharmacological treatment approaches should be tailored to the physical, cognitive and mental health of older patients, with a special attention to complications of polypharmacy. The use of pharmacotherapies in particular in relapse prevention for older adults is an area for further research. There is some evidence that naltrexone in older people can be used effectively in older people with alcohol use disorder. And it's noted here as well that older patients, as they age, tend to be on a variety of different medications. So a careful consideration does need to be given in order to avoid the complications related to polypharmacy prior to the commencement of any additional medication. So naltrexone, for example. Okay, so we have interventions for older adults that work, but a big problem is also getting older adults into services in the first place. For older adults, unfortunately, there are several service access barriers which impede their access to treatment. So some of the key service access barriers that older people may experience are things like a lack of recognition or a lack of insight regarding that there is an alcohol-related problem there in the first place. There's also a stigma and or embarrassment associated with alcohol and other drug use. There's a lack in older people, a lack of knowledge of drug and alcohol issues and services more broadly. There are a lack of availability of services, particularly services tailored to the needs of older adults. And there are also issues around the affordability of services. And finally, there is an issue of ageism. So this sort of attitude that what's the point in intervening at this life stage anyway. So finally, I did want to touch on this model that has been rolled out in the UK and has been designed specifically to overcome some of these service access barriers and to tackle risky drinking in older populations. So it's called the Drink Wise Age Well program, and it is a community-based, multi-level, multi-intervention prevention all the way through to treatment program. And it aims to reduce alcohol-related harm in people aged 50 years and over. So you can see the multiple components here. We've got this prevention and campaigning, and this is really about increasing awareness of risky drinking in older adulthood and tackling things like public stigma around alcohol and providing information and advice on alcohol for older adults in the community. Then we have the training and workforce skills development. So this is really about training for professionals who come into contact with older adults. Then we've got this individual and community resilience. So about increasing resilience among older adults who are experiencing problematic or risky drinking. And then finally, we've got structured support. Direct support for people over 50 who are experiencing alcohol problems. So in the outer circle of the program, we're really seeing a focus on prevention and campaigning and increasing awareness, tackling things like public stigma and providing information and advice about alcohol use for those aged over 50. So the activities included as part of this are things like local media advertisements, the promotion of the website in healthcare settings, so things like GP surgeries, hospital waiting rooms where older adults might be spending some time. They've also run public workshops, There's public information stalls, which have the capacity to screen and offer brief intervention as well. They've got a telephone helpline, a web chat service, and an excellent website. And they have also produced short films to tackle stigma about alcohol in those aged over 50. And we saw some examples of those films earlier in the presentation. So they also provide training manuals on their website. So training is being developed for those who provide healthcare services to older adults. So health and social care, for example, bereavement support. And there's a bunch of training manuals and easy read guides available on the Drink Wise Age Well website. So we've got things like the manual supporting older adults who have an alcohol problem and cognitive impairment, for example, as well as face-to-face training on offer as well. And unfortunately, it's just in the UK. And then we've got the individual and community resilience. And this is for people who may be starting to experience alcohol problems or at high risk for alcohol problems. So what they do offer is a 6-week resilience group work course for those aged over 50s. And this is called the Live Wise, Age Well program. So you can see the 6 different course lessons there, or sessions. They've got age well, feel well, think well, plan well, connect well, and live well. And then they've got a bunch of additional resources, tip sheets, reading materials available there as well. So some excellent information there designed for older adults in the community. So this can be delivered in workplaces or community settings, and it focuses on things like alcohol psychoeducation, stress management, coping skills, relaxation techniques, and mindfulness as well. And then finally, we get to direct support. And these are substance use services designed for older adults who are actually experiencing alcohol problems. So what they have as part of this are age-sensitive assessments. They've got that screening for cognitive impairment. They have adapted interventions. So these have been adapted specifically for older adults and focus on things like life stage issues and fall prevention, for example. And they also offer family support services. So really a great example here of a multiple level, multi-component program of activities really designed to have an impact on harmful drinking in older adulthood. Okay, so in terms of a summary, the main points from today, alcohol use is increasing in older adults, and so are treatment rates. Alcohol use is associated with things like brain damage, dementia, and cognitive impairment in older adults. These impairments may be reversible, so effective treatment really is key. There are Australian treatment guidelines specific to older adults in terms of recommendations for assessment, treatment, withdrawal management, and relapse prevention. And we also have individual and community level approaches to reducing alcohol use that work and need to be implemented more widely. So thank you very much, everyone, for coming along today. I look forward to your questions, and please feel free to get in touch if you have any questions you'd like to ask over email. Wonderful. Thank you.
Thank you so much, Louise. That was fantastic. Some really important and complex challenges for clinicians. And I think you've given a lot of people a lot to think about. We have had some questions come through, and I can see that you've already answered some of them. So if you have any other questions, everybody who's still there, please feel free to post them in the Q&A. But in the meantime, I'm going to get us started off by asking about a question that somebody had posted in the chat a little bit earlier about what medications are available for thiamine deficiency.
Well, the best treatment for thiamine deficiency is more thiamine. So depending on the level and the extent of the deficiency, that may be tablets or that may be through intravenous injection.
And in terms of the tablets, is that just over-the-counter B1 supplement?
Yes, and it should all be, as I think someone mentioned in the chat as well, really managed by the general practitioner or the person responsible, the practitioner responsible for the person.
Another question I had was, you mentioned quite early on in your talk that some of the reductions in drinking we've been seeing in some of the younger age cohorts haven't necessarily been seen among older adults. Why do you think that is?
It's a good question, and it's a question that lots of people are investigating at the moment. I think probably, I mean, there's two sides of that. The really interesting thing is why we're seeing such huge reductions in younger people in terms of risky drinking. I am interested in alcohol use across the lifespan, so I am across some of that research as well. And it's super interesting, you know, maybe the public health campaigns that we have developed for younger people are starting to get through to them, but it really is an open question at the moment as to why younger people are reducing, but we are seeing these stable rates of alcohol use in older adults, and that's over the past 15 years or so, and that's within that baby, so that's still within that sort of baby boomer cohort. If you do go back even more years, you'll actually see that the rates are increasing. So from previous cohorts, we are seeing significant increases in older adults drinking. It is limited to that baby boomer group, but it is also predicted that those, so the next generation is Generation X and the generation after as well, who have had significantly more alcohol use during their youth, will also come through to older adulthood and be drinking heavier as well. So this is a problem that's going to be around for a while, for the next few generations coming through to that older adulthood period. And it's just accessibility. You know, the baby boomers, you know, we're living through a time when alcohol use and other substances as well were a lot more accessible. So that might be one of the issues, but understanding why these trends are happening is something that I'm really keen to dig into further. But we, at the moment, you know, there's just theories. We don't have any definitive answers.
I'll have to have you back when you solve that one. So I could ask some follow-ups about that, but there are some more questions coming in, and I don't want to deprive anybody of their answers. And also, if we don't get through all of your answers, we will ask Louise to follow up with some of those and post the answers to those questions on our website, along with the slides and recording of this. So don't despair if we don't get to yours. A question about how you recruited for the Rethink My Drink RCT.
Yep, through Facebook. So baby boomers are all over Facebook. They're very easily recruited through Facebook, and 100%, all 900 of them were recruited through Facebook, the Facebook advertising campaign. And like I said, we had, you know, really long timelines for recruitment, and we ended up smashing those. We were able to recruit people really quickly, really demonstrating this need for a treatment like this out there. And I will say as well that, you know, we had the full range of drinking. We had some really heavy drinkers taking part in that program as well.
It's really interesting. And I guess I was thinking, as you were talking about some of the interventions you were speaking to, some of the older people in my life and how they might go with online interventions. Do you find that some older adults are any more or less keen than the younger cohorts in hopping online and engaging with those types of interventions?
We do have an equity issue here. There are, you know, well, more and more older adults are very much technologically savvy. They are able to use technology and are very happy engaging with online interventions. But there is this issue where those who aren't as likely to use online resources are possibly those who really need it the most. So this is just one tool that we can use for older adults. It looks like it's going to be a good tool, but certainly other approaches are needed, and really maybe thinking about that broader drink wise, age well approach is something that we need, that public health approach, as well as some of the more individualized treatments like Rethink My Drink.
Tricky as well, because I guess with the online interventions, you can overcome so many barriers, but then potentially throw up others.
Yes, exactly.
Another question, would you prescribe diazepam when a patient wants to manage withdrawal symptoms but has not stopped drinking alcohol but plans to stop drinking alcohol? Not sure whether you can answer that one.
No, look, the limits of my knowledge are in the research world. I'm not a clinician. I'm wondering if maybe someone out there might know the answers to that.
We can come back to that one.
I believe you would need to be abstinent prior to it was the benzodiazepines were in terms of relapse prevention. So we're assuming that someone has stopped drinking, they're abstinent. I think you would need to be abstinent in order for those sort of medications to be prescribed.
Are you able to comment on who might be able to be safely managed in the community if a patient decides to stop drinking alcohol, if they were previously drinking quite a lot a day?
I would think it would be someone who has excellent support network, someone who has a clinical team out there in the community that is able to be vigilant and to look after them. I mean, you can get very sick from withdrawal from a lot of substances, but alcohol withdrawal is the only withdrawal that is actually could be lethal. So we do need to be really careful when managing alcohol withdrawal in the community.
Yeah.
This is that.
Yep. Thank you. Do you know of any programs that are online and specific to Aboriginal community members like Rethink Your Drink?
I think I know that at Matilda Centre we are other researchers are developing resources specifically for Aboriginal and Torres Strait Islander populations. I think they're more youth focused. I'm not aware of any. I would be very surprised if there were any available, really focusing on that older age group. There's very little focusing on older age groups in general, and then when we get down to specific populations, there's nothing. There's very little, and we need more out there.
Thank you. I think that there are still a few more questions there that we haven't got to, but I think we might try not to run over time for once.
Chris, thank you so much. I really am more than happy to take any questions via email.
Thank you. And I'm aware that you've given us your email address, which is sometimes dangerous, but please feel free, if we haven't got to your question, to email Louise directly, and the ones that are remaining, we will send to Louise and ask her to post her answers to our, we'll collate them for you and we'll put them online.
Yep.
But just before we end, I just want to let you know, while I've still got you captive, that you can find out more about our information, about our guidelines, which this webinar series is linked to, and our other resources at our website there on screen, and let you know about our next webinar in our series, which will be on the 4th of June, which is actually next week, I think, where Dr. Marley Bauer will be speaking about the role of social connection and loneliness in the well-being of people experiencing homelessness and substance use. And then in August, we have Dr. Vicky Giannopoulos, who will be speaking about depression and alcohol and other drugs. But thank you so much, everybody, for having joined us for this webinar. If you would like to see the recording, register for our upcoming webinars, or have a look at our library of previous webinars, you can do that via the website. And until then, thank you again for joining us, and thank you so much, Louise, and please enjoy the rest of your day, and I'll see you all soon.